Today's webinar is dedicated on a topic related to collaboration, the collaboration between medical physicists and our colleagues from the Medical and Biomedical Engineering Society. So I have the pleasure to announce the joint IOMP-IFMBE webinar dedicated on the Clinical Engineering Day 2022, Management and Maintenance of Medical Technologies. The Clinical Engineering Day is an event that IFMBE Clinical Engineering Division celebrates since 2016, and it is very much similar to the International Medical Physics Day. The Clinical Engineering Day is focused on promoting the recognition of the clinical engineering profession. So with these introductory words, I would like to also introduce the moderator of today's webinar, Professor Francis Hasford, who is the chair of the IOMP Publications Committee and vice president of the FAMPO. Dr. Hasford is a medical physicist and deputy director of the Radiological and Medical Sciences Research Institute in Ghana Atomic Energy Commission, and the immediate past head of the Medical Physics Department of the University of Ghana. He is project scientific consultant for the International Atomic Energy Agency, regional project on medical physics in Africa. So Francis, over to you.
Thank you, Magdalena, for the introduction. So I'll share my screen and then introduce our speakers for today. So today we are very privileged. We are going to have two distinguished speakers in the person of Ernesto Iadanza and then Magdalena Stoeva. So our first speaker is going to be Ernesto Iadanza. Ernesto Iadanza is a senior assistant professor in bioengineering at the Department of Medical Biotechnologies, University of Siena, which is in Italy. And he is nationally qualified as associate professor in bioengineering. He is currently a member of the International Federation for Medical and Biological Engineering Administrative Council and chair of its Council of Societies. He received the IBM Faculty Award in 2013 and the IFMBE CED Teamwork Award in 2019. He is the editor-in-chief of the Clinical Engineering Handbook, second edition, which is published by the Academic Press in 2020. He's associate editor of many biomedical engineering journals. He's a supervisor in over 200 graduation theses, author of 190 publications in international books, scientific journals, volumes, and conference proceedings. So this is our first speaker in the person of Professor Ernesto Iadanza. So please, you can have the floor.
Thank you very much, Francis. Thank you so much. So I'll try and share my slides if I manage. And okay, here we go. So thank you to IOMP and to Magdalena in particular for putting together this webinar today. I'm very excited of being part of it because, you know, IOMP and IFMBE are sort of siblings, if you want, under the umbrella of IUPASM, which is the International Union for Medical Physics and Biomedical Engineering. And we are both in direct relationships with WHO. So we have a collaboration which is going along for quite a while now. And today I will be talking about cutting-edge methods for management and maintenance of medical technologies, which I think is a topic which might be interesting both for medical physicists and for biomedical engineers who today are in a very large number participating to this webinar. So just a couple of background information about my biography. Yes, I'm here at the University of Siena as senior assistant professor in bioengineering, And my background is basically in clinical engineering and biomedical engineering. I've been part of IFMBE in different roles, one of which was the chair of the clinical engineering division. And I'm mentioning this because, you know, we are in the Global CE Week. The Global CE Day was established in October 21st in Hangzhou, China in 2015. And I'm quite happy to remember that I was there in that moment. It was the first Global CE meeting. So from then on, many things have been happening, and also our profession has been changing a lot. Today, my role is the chair of the Council of Societies. Just very briefly, you know that IFMBE, the International Federation for Medical and Biological Engineering, is a federation of national and transnational societies, counting today, I think, more than 65 societies from all over the world. Well, in the Council of Societies, we have nowadays 5 regions. It used to be only 4, but now we also have the 5th region, Africa. So we are actually covering 5 continents. And this is the house where the societies can discuss and also put forward some of their issues and proposals, and sometimes also complaints, of course. And I've been editing as editor-in-chief the Clinical Engineering Handbook, the 2nd edition, and this was quite challenging because, well, it was a choral effort with more than 150 colleagues from all over the world. But when I say challenging, is because the 1st edition, in my initial idea, was just to be updated. But then I realized that in few years, in less than 15 years, the profession has been changing really in a significant manner. So we have now things like health technology assessment, like human factors, like information technology and mobile apps and so forth, that were completely missing in the 1st edition of the handbook. So I will try today to focus a bit on what methods we might use to cope with this moving target, if you want, also with this technology which is changing. We could define technology as, well, medical technology as a variety of solutions or products or services can be used to save and to improve people's lives. So we need some effective tools and some methods for managing this technology. So how can we do what we usually call HTM, so a health technology management? Well, first of all, historically, management meant for 70% maintenance. Well, nowadays things are changing a lot, but still maintenance is a very important part when it comes to medical technology. So a few years ago, well, 10 years ago, 12 years ago, actually, in 2010, Dr. Vincent Wang came out with this interesting acronym. I guess most of you know EBM as evidence-based medicine. Well, evidence-based management or maintenance is resounding that acronym on purpose, of course. So the idea is, okay, why don't we measure and assess the outcome of what we are planning and what we are doing to see if we are in the right pattern, if you want, or if we need to change something or to improve our, for example, maintenance protocols. So every single time you talk about evidence, well, you have to remember that evidence comes from data. So the actual problem is always to have some good, well-collected, clean data. We tried to put in place this method in a large hospital here in Tuscany, in Italy, which is the hospital of Careggi, and the outcome of that exercise is can be found in this publication. on the Medical and Biological Engineering and Computing Journal, which is the flagship journal of IFMBE, published by Springer. So we went to the hospital of Careggi, which is maybe the largest in Tuscany, with more than 16,000 pieces of equipment, and we tried to get and capture some data to analyze. We had, of course, to narrow down to 13 classes of medical equipment, just focusing on operating rooms and ICUs, intensive care units, for two reasons: many pieces of equipment with different types of equipment there, and also maybe the two most critical areas where we wanted to start proving this method. Well, it turns out that you can start with corrective maintenance and with scheduled maintenance. And what you want to do there is to try and assign a code, so classify your failures, your faults, in order to be able to understand where, for example, there are some spot problems, or if you can find a trend, you can have some indicators telling you that you are overcoming some thresholds, or maybe you just have some trends that you want to address. And for doing that, what you need is actually to analyze every single work order, and both for, as I was saying, for corrective maintenance and also for scheduled maintenance. So what we tried to do was using the same exact codes we found in literature from the already cited friend Vincent Wang. And this turned out to be not so easy as a task to be performed. So you start with your database and you extract your data, then you have to analyze them. And sometimes, as you can see, there's not enough information in the report itself for many reasons. So in this case, Valentina Gonelli, who was the scientist in charge of the study, had to actually interview the technicians in order to ask them, would you remember what happened that time? Should we classify this as an accessory related problem, or maybe it was related to a wrong network connection, or maybe it was related to battery, or you didn't find any problem, and so forth. So very time consuming and quite complicated process. So we wanted to understand with new technologies what we could do to improve this long process. So we came out with this set of 20 key performance indicators for organizational aspects, but also for costs and so forth. And then once you have that, you can compare, for example, like in this slide here, you can compare, this is a multi-parametric monitor. So you can compare your scheduled maintenance and your corrective maintenance. So for example, if for 95% of the times, I have NPF, which stands for no problem found. So that means that it is quite common. I go there for scheduled maintenance. I find no problems. And then if I analyze the corrective maintenance, I can see that there are some unpreventable failures. So what is the relationship between these two? So what actually was prevented with my scheduled maintenance and what could not be prevented is part of the analysis. You could just, quick example, but it's part of the analysis you could try and perform with this kind of approach. And we also compared with literature, we compared our results. So one interesting outcome is also then that using a sort of a standard classification, you will be able to compare your performances to literature, or maybe to other departments in the same hospital or in other hospitals. So you start providing and analyzing evidence. But this is starting to be applied also in other hospitals. In this case, I'm sorry, it's in Italian because it's the actual abstract from a public tender in a large hospital in the northern part of Italy. So they proposed, and they are now applying the same method I was showing you before. So data should start flowing. And here, in a couple of years ago, while I was chairing the IFMBE Health Technology Assessment Division, and here you can see the whole team of elected, co-opted members and collaborators from all over the world, as you can see, from Canada to Hong Kong, to Italy, of course, UK, and so forth. We started to look for who is doing what with new technologies, like, for example, sentiment analysis. Sentiment analysis is a tool which could be used also for assessing medical devices and medical technologies. This was our idea, and it turns out actually that it was not so new as an idea, because we found quite a lot of works, half of them from the United States, but also China, Italy, Sweden, Netherlands, Spain, UK, and so forth. And you can see that the data extraction methods were changing a lot, were very different, but many of them were using ML-based approach, so machine learning approach, which means that machine learning and artificial intelligence, as we all know, is entering our field. So how should we cope with it in terms of, for example, training or our syllabi in academia, for those of you who are involved in teaching in academia? And this is one more work we tried to do to understand how we could leverage these cutting-edge methodologies for management and maintenance. And here, what we tried to do was analyzing this data from the FDA mode, the manufacturer database for adverse events. We realized that, and you can see quite clearly in these slides, in the last, let's say, 10 years, more or less, there was an unbelievable growing in health information technology related adverse events. So, and of course, things have been changing, and now we have mobile, and now we have medical software, at least in Europe, starting 2027. Also a software off the shelf, so not software used together with an hardware, but a software per se can be classified and should be classified as a medical device if appropriate. So you can see that now we have something new to cope with, and natural language processing, or NLP, could be a tool that we might want to use to investigate this kind of problems. So what we have here are documents. So it's natural language. It's not classified in a very structured way. It's not a database. It's just a set of reports with some narrative, hopefully in English, but not always in English. So we have many things to deal with, and there are different methods. In our study, we used Google BERT, which is one of the most advanced tools we have now for natural language processing. And we used, as I said, the MODE, Manufacturer and User Facility Device Experience database from FDA, just because it is very much full of data and documents compared to the others. We will have soon the EUDAMED, European Data Bank of Medical Devices, in place. It's starting to be in place, but still it's not comparable in terms of numbers of documents we could analyze. So we started with 3,700 reports, and we had to classify them using clinical BERT, which is a particular type of BERT, which is trained specifically on clinical language. And this is the colleague who is still working with it on it, who is Alessio Luschi, a Ph.D. candidate at the University of Florence. And we wanted to label the hit reports to understand what is actually classifiable as a problem related to health information or not. And it turns out that the accuracy is really high, and so is the precision, the recall. So we have quite interesting preliminary results, and we are going forward in that direction. When it comes to AI, there's also some other big issues to be taken into account, like ethics, and these are the ethics guidelines for the trustworthy AI published by the EU Commission in 2019. And this is becoming a very important issue to be considered when you want to use machine learning and artificial intelligence tools in your work. So, for example, this is a brand new article on the methods and approaches of explainable artificial intelligence. When it comes to medicine, what you want is not a black box like an AI telling you this is black or white, this is healthy or not, but you want this to be explainable. And the same is in managing your technology. And then you have some new interesting tools which are coming to the field, like augmented reality aided maintenance. There is stuff which is already on the market nowadays, like this one here. And also, and this is my last slide, you could also leverage some semantic ontologies for computer-aided facilities management together with your technology management, because of course we are using our technologies in our facilities. So you want to link this to information, because the right piece of equipment should be used in the right place and vice versa. So like in this example, you can access technical information, technical data linked using a semantic ontology to your specific room, to your specific device. So I hope I was in time, and I tried to give you just a glance of how many different tools we might have today, but on the other side, we need to understand which ones we could use or not, and also we should involve in our teams some new competencies which might be lacking today, because maintenance is not just a matter of screwdrivers anymore, but it could be a matter of artificial intelligence or natural language processing or semantics ontologies and so forth. So we need new competencies for that. Thank you.
Thank you very much, Professor Ernesto Iadanza. It's been an interesting presentation and quite enlightening, of course. So I would want to inform participants to send their comments or questions in the chat box. It will be read out to our speakers after the second presentation, and then they will respond to them. So we'll move on to our next speaker. So I'll quickly project. Yes, so our next speaker is in the person of Professor Magdalena Stoeva. So Professor Stoeva is the Secretary General for the International Organization for Medical Physics, and then also Secretary General for the International Union for Physical and Engineering Sciences in Medicine, the IOPSM. She's the editor in chief of person in cooperation with the World Health Organization. Dr. Stoeva has experience in medical physics, engineering, and computer systems at academic and clinical level, as well as organizational and international experience. Professor Stoeva's work is directly towards technological advancements as a driving factor for contemporary healthcare, So Professor Stoeva, please, the floor is yours to deliver. Thank you.
Thank you, Francis. Let me share my screen. First of all, I would like to thank Ernesto for this wonderful presentation and for explaining in detail from the engineering point of view the entire process associated with equipment management. This, of course, is a huge topic and can hardly be covered within a small presentation or a webinar, but certainly gives an idea of the medical physicists, what the responsibilities of the clinical engineering are, and how we can and where we can touch base, and where we can benefit from their expertise. Additionally, I would like to mention that actually Ernesto is one of the contributors to the Medical Physics Encyclopedia, leading the group dealing with the clinical engineering terms. So with this, I would like to proceed with my presentation on equipment management for medical physicists. So medical physicists are quite an interdisciplinary profession. And actually, we have passed a long, long way during the past almost 130 years from the left image to the right one. And this has been very successful development thanks to the cooperation between physics and technology, and to the implementation of the physical principles and some technological solutions. Speaking precisely of medical physicists and their role in healthcare, I would say that we medical physicists are trained in various disciplines, and also could sometimes be very highly specialized. We work in the field of physical and engineering sciences in medicine, and quite often we actually serve as the liaisons between the healthcare and the technology. So we practically often have to translate the terms of the technology into understandable terms for the medical staff and also for the patients. Medical physicists are involved in the quality and safety, and all these are key aspects related to the application of the various physical principles in healthcare. So our role in ensuring quality and safety is a primary subject of our activities in diagnostic radiology, radiation oncology, nuclear medicine, and all the equipment and the procedures in these branches of the contemporary healthcare. And as you can see on the right-hand side, this is the distribution of the medical physicists worldwide, presented by the IOMP. Unfortunately, quite uneven distribution, which opens a lot of questions. And some of these questions and issues are directly related to the equipment management, and are turning to one of the main reasons why we are having this subject, equipment management for medical physicists. So let me start with the challenges first. Thinking of challenges that are presented to medical physicists, I shall start first with the requirement to have interdisciplinary knowledge, but also practical skills. Also, in many areas, medical physicists actually work alone or in small teams, which makes them very important in terms of supporting the technical part of the healthcare. Quite often, medical physicists, especially in the low and middle income countries, are the only technical person on site. So they often are asked to conduct various technical activities not directly related to medical physics, but activities that sometimes require having some engineering knowledge or skills. Medical physicists are involved in clinical, technical, academic, and research activities. They deal quite closely with the on-site equipment management. They are definitely involved in the quality and safety of the equipment in the diagnostic imaging, nuclear medicine, and radiation oncology departments. And this is one of their primary activities. And of course, there are specific challenges that are only available and can only be understood by those who are working in the low and middle income settings. So the role of the medical physicists in healthcare, apart from, like I said, dealing with their primary involvement in quality assurance and safety of the equipment, requires some clinical skills. And the reason to have such skills, number one, falls behind the responsibilities that they have on their site. So their primary responsibilities, of course, are related to diagnostic radiology, nuclear medicine, radiation oncology, radiation protection, etc. But there are quite a few additional responsibilities related to common activities, which involve equipment management, risk assessment, equipment maintenance. These are especially clearly visible when it comes to the developing regions. So in order to be successful in delivering what is expected from a medical physicist working in such areas, they need to get a proper education and training. And this education and training should be gradually built through delivering the necessary knowledge for the medical physicists to develop some basic engineering skills. And this is where we can actually rely on our colleagues from the clinical engineering, because they are the perfect trainers. The local clinical engineers could be the primary choice for trainers when it comes to equipment-related medical physics courses. And then, of course, comes the on-site collaboration between medical physicists and clinical engineers, which is crucial for the success of the diagnostic and treatment procedures in contemporary healthcare. So the whole idea behind delivering some basic clinical engineering training for medical physicists started almost 20 years ago, actually in 2002, during the ICTP College on Medical Physics. And it started with a survey among the students who attended this college. The idea behind the survey was to check the need for engineering skills among the medical physics students and practitioners from the low and middle income countries. And the results of the survey showed that nearly 100% of the participants supported this idea, and actually proved that they have faced such challenges in their own activities as medical physicists. So in 2015, a module on clinical engineering skills was introduced as part of the ICTP training curriculum for medical physicists. This is how actually the education and training turn into a key for a successful development strategy in increasing the knowledge of medical physicists towards some engineering areas. And there are many courses nowadays, because 20 years ago, there were only 2 courses, one in New York and one in London, with some engineering topics, subjects in their curriculum. Nowadays, there are a lot of them, but the key course for the low and middle income countries is the ICTP College on Medical Physics, which for over 30 years of existence has already produced over 1,000 medical physicists following the principle train the trainer. So this course is with a specific focus on the low and middle income countries development, and it is a primary source for education, training, continuous professional development, and which is even most important is the capacity building skills in the medical physics that are delivered as a result of this college. The other source of information for basic clinical knowledge and skills in medical physics is the Medical Physics Encyclopedia, with its first edition in 2012, which had primary focus on medical physics. And then the second edition, produced in 2021, officially recognized the need for extended knowledge and skills for medical physicists. And working towards extending these skills, the editorial team decided to cover various aspects related to the equipment management. And here comes the very significant contribution of the clinical engineers, which was kindly coordinated by Dr. Ernesto Iadanza. And then let me go straight to another publication, which is quite useful, again, for the low and middle income countries and the developing regions. This is the book on medical equipment management, and this is practical view of the medical equipment management, mainly for developing areas. It covers medical equipment life cycle, risk regulations and governance of medical devices, procurement, contract management, clinical training, technical support, equipment evaluation, safety, quality and auditing. So all these activities actually fall into the medical physicist responsibilities, and are another proof that we do need to have some basic clinical engineering skills and training. So with this, I shall switch to slightly more practical stuff, listing the main reasons for procurement when it comes to dealing with the medical devices in diagnostic imaging, nuclear medicine, and radiation oncology. So it could be either a new service, various types of upgrading or even downgrading, new procedures, replacements, new equipment, or just to comply with the various types of regulations, or a research and development activity. And before the actual acquisition, there are a few factors that need to be deeply considered. This is something that quite often falls into the responsibility of the medical physicists, because management teams of the hospitals often invite medical physicists as team members of the group handling the and managing the acquisition of the new equipment for these departments. So the main factors is, number one, to make sure the correct device is selected, then make the correct assessment. Of course, suitability for intended purpose has to be assessed, the procedures for accepting new devices. The ease of use is a critical item, which is of great importance to the medical staff. So this should be considered and even further discussed with the actual users, the radiologists and the technicians. Then don't forget to consider the user experience feedback from the clinical environment. Again, the medical staff is a very good source of information for this. And last but not least, to rationalize the range of models versus diversity based primarily on your clinical needs. And the factors to be considered before the acquisition related to this rationalizing, that was the last item on our previous slide, actually are focused on documentation and monitoring, the the user-specific documentation and guidelines and the way they are prepared, specific documentation for physicists, for radiographers, for radiologists, etc. This is something which is important not only for the during the installation, but also during the entire life cycle of the equipment. The timing of the update and the monitoring intervals are also critical. And of course, the evaluation of the readability of the manufacturer's documentation. So this is just an example of how real documentations can be compared. So in both cases, we have X-ray tube characteristics, but since they come from different manufacturers, they look in a different way. So quite often, medical physicists need to develop skills to be able to read and interpret data coming from different sources and to be able to compare this data, which sometimes may not be compared directly. Like this second slide also shows the comparisons of the digital radiography systems. And then we come to the word that we are all usually afraid of, the risk and risk management. Risk management, risk assessment is a key aspect in every equipment management procedure. So we need to be able to clearly define our potential risks and classify them according to a preset semaphore system. Of course, normally we should be running within the green values, but sometimes moderate risks that are unlikely to happen are also acceptable. What is important is the risk recognition. So the presence of risks within the red regions are not so dangerous if they are properly recognized and if the facility has the proper contingency plan in case such situation occurs. Then medical physicists are quite often involved with the equipment installation and the installation support services. So they are involved in checking the existing regulations, dealing with experts. Of course, always make sure that the expert advice received is official and signed. Then the installation support services, although practically delivered by the manufacturer, are also running in very close cooperation with the medical physicists. And there are a few items that medical physicists need to be aware of when it comes to installation support services. And these items are related to the way the installation is going to be carried out, the building and utility services that are required, any special calibration requirements, communication protocols, need for endorsement of the installation, of course, the linking with the equipment with the existing infrastructure, and last but not least, the disposal procedure, which is the end of the life cycle of the equipment at your site. Then there are a lot of activities associated with pre-use setup, testing, installation, and commissioning. In the interest of time, I shall skip this slide and continue to the next one, which is also very important. It is a key point when it comes to warranty and out of warranty support, because both the warranty and out of warranty periods actually form the equipment life cycle. And when it comes to warranty, it is important for medical physicists to be able to assess the warranty plans and coverage, as well as the possibilities for extended warranty and the way parts and labor are covered within the warranty and the insurance contracts. Then comes insurance plans, the way force majeure situations are covered. Of course, the testing that are conducted by the manufacturer, by third parties, or having your own facility tests. The software updates, which is critical. The software is the soul of the equipment, and the equipment won't survive if we don't have the proper software. Then we are directly involved in the regular performance checks that are done by the manufacturer, but again, with quite often with the assistance of the technical person on site, which, as we already mentioned, in the developing areas is quite often the medical physicist. The spare parts, the presence of spare parts list for critical parts and the availability of these parts, DTA, the standard price list, and all activities related to the replacement, buyback, and disposal of the equipment. And then comes the maintenance support, which are pretty much standard procedures. I have included a list here, which you may find useful in your professional activities. Of course, we all need training. So availability, type, and scope of training are important for every situation when we deliver new equipment in the location. So the location of the training has to be properly checked, as well as the availability of initial and continuous training. And my last slide shows here the two cost values, the cost of acquisition and the cost of possession. So the cost of acquisition are these direct one-time costs that we usually pay when we buy the equipment. It does have the cost related to the equipment itself and some indirect costs related to infrastructure, organizational staff, as well as add-ons like software, test objects, measurement equipment, licensing, certification, training, etc. But don't forget the cost of possession, because quite often the cost of possession being added to the initial cost may double the total cost of the equipment. And the cost of possession are the regular fees that we pay for the contracts, maintenance, fees for consumables, out of warranty service, spare parts, the cost of disposal. So these are very important. And here I have included references to all the external material that helped me prepare this presentation and deliver the content. And with this last slide, I would like to thank you and hope we shall see each other again.
Thank you very much, Magdalena. Very insightful and very packed. So much information delivered in a short time of over 25 minutes. Very, very good there. So there are a number of comments that are coming in, and thank you all the participants for sending in your comments. So first off, to Ernesto, what would you say about countries pursuing certification for clinical engineers? You know, with medical physics, the certification for medical physicists. Should clinical engineers also do same, or what is your opinion about this?
Yeah, I was a young child the first time I heard this question, and still I don't have a final answer. I mean, it's something we've been discussing a lot in the Clinical Engineering Division at IFMBE. We had a program for that, and it's been investigated a lot by James Ware, who is a great expert about this kind of topic. I don't want to run out of the question. For example, in the US, you all know that being a clinical certificate clinical engineering is vital if you want to have a good job, no? Because it's requested by the hospitals for hiring you. That's it. And there's a recent experience in Italy, there's a national certification now. So you have some colleagues who are actually performing some examinations on other colleagues and giving them certification. Not so many of our colleagues are undergoing this process. Why? I think, well, first of all, because it's quite new, but I think it's because it's not mandatory. It's not recognized in terms of you earn more, or you have your job in an easier way, or maybe there's something that only if you have a certification you can do or not. So my suggestion is to go hand in hand with the legislative part. So you need to have an actual value of this certification, which is costing money, a lot of money in this case, and it should provide you with some touchable advantages, you and your patients and your colleagues go forward. But that was a tough one.
Thank you very much, Ernesto. So Magdalena, you spoke about contract issues, warranties, and all of that. As a medical physicist, we know that there are challenges when it comes to contracts and some of these things in setting up medical equipment in the hospitals, especially in cases where medical physicists are not involved in the procurement issues. As experienced as you are, can you offer or proffer some advice in this direction on how to better save the situation, especially in low and middle income countries?
Definitely, medical physicists are not always involved in the procurement of the medical equipment. And unfortunately, later on, they are held responsible for the proper operation and the proper deliverables when it comes to using the equipment in practice. And sometimes wrong choices are being made by people that are not professional in medical physics or medical technology, because we cannot expect management to be professional in every single aspect of the healthcare. So my advice, regardless if it comes to developing or developed regions, is to work closely with the national organizations, to work closely with the hospital boards, and explain in detail the role of the medical physicists and how actually their expertise can be useful and beneficial for the procurement of the medical equipment, and slowly and gradually build kind of advisory boards or committees that, being attached to the management of the hospitals, can contribute to the procurement of the medical equipment. And I think what I said for the medical physicists is also valid for the medical engineers.
Thanks, Magdalena. So Ernesto, in your practice, how has the link between medical physics and clinical engineers, how has it contributed effectively to the outcomes of your work?
Thank you. Yeah, I've been working a lot with medical physicists since day one in my research career, because methods are really overlapping sometimes. Magdalena was showing risk management. I've been working a lot on risk management, and for example, tools like IFMBE or IFMBE, or even more complex tools like fuzzy IFMBE, I have a publication on that specific topic, could be used very effectively. And also the role of clinical and biomedical engineers in manufacturing the equipment. For example, we have a joint lab with a company, I could tell the name, it's Epica Imaginalis. It's a multinational between the United States and Italy. We have a joint lab with a university where we train our clinical engineering and biomedical engineering students in assessing the risks in a proactive way while designing the equipment. And that same equipment, I'm talking about CT scans, will be managed by our medical physicists colleagues once in the hospital. So there needs to be a better, I would say, dialogue. There are some occasions like the great IOPAS conferences we have once every 3 years, which is a very good way to have dialogues, or maybe the Health and Technology Journal, which is the scientific journal of IOPAS as well, is a very good way to provide clinical engineers with some articles they might not go searching for, and vice versa, no? In order to have this sort of seeding in both ways.
Yeah. All right. Then, Magdalena, in one of your slides, you showed the distribution of medical physicists in the world, and we could see it is not uniform. And especially for the low and middle income countries, there's a lack of medical physicists, and the levels at which it is needs urgent attention. And I presume it is so also for clinical engineers. Then, for Ernesto, on some of your slides, you mentioned the use of artificial intelligence, machine learning, contributing to maintenance of clinical equipment. How best can we help the situation for low and middle income countries to bridge the gap? Because applications or use of artificial intelligence, machine learning, we know it's not as developed in the low and middle income countries. These are emerging economies, right? How best can we save the situation, or maybe contribute to helping the situation currently?
Excellent question. Thank you, Francis. We had a summer school last month. Well, in September here in Italy, and it was co-organized by the National Group of Engineering and IFMB, specifically on this topic. So how can we support low middle income settings, not just countries, because sometimes you have a developed country with some specific low income settings you need to address. So it's quite a complicated, of course, topic and issue, as we all know. But I think that artificial intelligence might actually be an asset for achieving that goal, because more and more we are using open software, more and more we are leveraging cloud, which is not always free, but we also have some very large initiatives and transnational projects also for providing this kind of services. So having a decision support system which is able to crunch lots of documents and information coming from all over the world in order to provide the best, quotes, best solution for that specific setting, I think it's a great way to save low resources. Once you have only €1 to spend, is it better here or there? Should I use it for buying stuff or for preventive maintenance, or maybe just save it for corrective maintenance and so forth? This sort of support can be very well achieved with artificial intelligence, in my opinion.
All right, Magdalena, you have any contribution to this?
Yes, thank you, Francis. This is really a very good and very hot question, because the development of the medical physics is really quite uneven. Not only the number of medical physicists worldwide, but also the access to technology is quite unevenly distributed. And I think that the primary key to solve this is through education, training, and networking. And similarly to what Ernesto mentioned, last month we had our medical physics college in Trieste in Italy, which is directly focused on the low and middle income countries and the capacity building in the field of medical physics. So with the support of education and training, with sharing knowledge and expertise by well-recognized professionals in the area, I think we can bridge the gap slowly but effectively.
Thank you very much. Unfortunately, there are lots of questions, but unfortunately, due to time, we'll not be able to go through all of them. So we'll be winding up so soon. Coming from a middle income country, and I know what pertains in those parts of the world. I think, in my view, it's about time we build the bond between medical physicists, clinical engineers so tightly to be able to offer support to each other and then to be able to build up together. And through that, I think we can fast track the process by which the two professions would gain the needed recognition and to be able to make the needed impact. I believe in unity lies our strength. And so I believe this webinar we've had is one of the steps by which we'll continue to bridge the bond between medical physics and biomedical engineers, clinical engineers, and all of us together so that we achieve our aim. So we'll be winding up so soon. It's, according to my time, is 1 p.m. GMT, and we are supposed to be ending there. Unfortunately, it's been very interesting and so much information given in just 1 hour. And I would want to thank our speakers, Ernesto and then Magdalena, for giving us so much information. And I believe the discussions will continue from here. It will not end here. There are lots of questions. I'll refer them to you for you to be able to address them and then to be in contact with the participants as well. So let me project my slide. The announcement to be given, our next webinar, which is going to happen, is going to be on 7th of November, which is just a couple of weeks away. And that is the webinar that is going to be celebrated, the International Day of Medical Physics. And there's going to be contribution from IOMP and then also the regional organizations of the International Organization for Medical Physics. So on this note, I would want to thank the president of the Federation, the International Organization for Medical Physics, and all executive committee members and then organizers of this particular webinar. It's been very insightful and very interesting. So on this note, I would want to say good morning, good afternoon, good evening to everyone, wherever you are in the world. And then hopefully we'll meet very soon on 7 November for another edition of the IOMP webinars. Thank you all and enjoy the rest of your day.
Thank you very much. Have a good day.
Thank you.